Hello, my name's Dr. Matt Jones. I'm a consultant anaesthetist in East Kent Hospitals in the UK, and we're going to be looking at some newer techniques relating to central venous access catheter placement on the intensive care unit. So when considering placing a central venous catheter or centrally inserted central catheter, it's always important to understand the indication for that catheter. Is it worth considering if there are other alternative intravenous routes that may avoid the need for a catheter altogether? If we've decided that there is a clear indication for a central line, we first of all need to make sure that the patient, if they're awake, has undergone an informed consent process. Important to now understand if there are any particular contraindications to central venous access placement. A couple of things that we really need to have a look at. First of all, is the patient allergic to anything? Does the patient have any clotting problems? It's worth having a discussion with the patient to ensure that they understand what's going to happen, explain the procedure, the risks and benefits, and why we're going to be doing it. As part of our preparation before we insert the line, it's important to have patient on adequate monitoring, including ECG. We can also use the ECG monitor as part of an ECG tip location so that we can accurately place the tip of our line. What I prefer to do is reconfigure the ECG trace to make it easier for us to be able to ascertain the size of the P wave as we're placing the line. So essentially what I do, I found is much more helpful, is to increase the size of the ECG a little bit, and also just change the sweep speed from 25 millimeters to 50 millimeters. And what this does is spreads out the ECG complexes and makes the P waves a lot more discernible and visible, particularly in patients who are tachycardic, which is often the case on the intensive care unit. So before we start, it's recommended to do an ultrasound assessment of the central veins to ensure that we have selected an appropriate site. We're looking at the size, the patency, the direction of the veins, looking at the filling as well, so we can see how large or small, whether they collapse with respiration or ventilation. But most importantly, we're also looking for the location of adjacent structures. When we come to do the procedure, we want to be happy before we start that we're going to be able to access the vein very safely without damaging any adjacent structures. Last thing we want to do once we've selected our vein is just select the most appropriate insertion site. This is related to aftercare. It may be related to whether the patient has a beard or any other anatomical features that may suggest to you that you want to use one particular approach rather than another. We come to our vein assessment. I've set up my ultrasound machine, optimized my image, making sure that my depth and the gain are appropriate for the environment and the use. And we're just going to have a little look and see if we can do that vein assessment. My preferred vein for central venous cannulation is the internal jugular, the right internal jugular. So I'd usually have an assessment of that first of all to orientate our probe, make sure we can see. And here we can see very clearly the right internal jugular sitting on top of the carotid artery. I can use a compression test to check which vessel's which. The vein is nicely compressible. It's nice and straight, it's got good filling, so this to me would be a suitable vein. Okay, we can track that down into the chest by tilting the probe down. Sometimes can see a valve coming across. There we are. I'm very happy that we've got good filling, it's an appropriate size, direction. I've identified all the adjacent structures. Once we've made a vein assessment using the ultrasound and we have an understanding or an idea of where we're going to insert the line, in this instance I'll probably be going around here, it's worth making a rough estimation of the distance that you're going to need, so to inform you as to what sort of length of catheter you might need. We normally measure just down towards the manubriosternal joint and add a couple of centimeters on, and we can see that that's quite a short distance. So in this instance, using a relatively low approach on the right internal jugular vein, a 16 centimeter line may be long enough, but we can always go a bit longer, up to a 20 centimeter line, because it's usually preferable to have a line that's too long, so that you can reach the cavo atrial junction but have extra line on the outside, rather than having a line that's too short and not having enough space on the outside of the line for your securement and fixation system, and having to leave the line too short in the superior vena cava.